My name is Ann Albert. I am the Klatt Family Director for Public Programs here at the Herbert D. Katz Center for Advanced Judaic Studies at the University of Pennsylvania, welcoming you to the first program in a series on health and healing in contemporary Israel that the Katz Center is co-presenting with the Weitzman Museum of American Jewish History and the Koret Center for Jewish Civilization, together with Tel Aviv University and ANU, the Museum of the Jewish People. So this rather august collection of institutions that I'm very, very pleased to be joining with has come together to devote some time to understanding contemporary issues related to health and medicine in Israel. Israel has a well-earned reputation for innovation and advancement in medical science, and throughout its history has placed a special focus on public health as part of the state-building enterprise. So in this series, we're bringing together practitioners and scholars, demographers, anthropologists, physicians, community leaders, to talk about how Israelis are responding to new challenges and opportunities, including responses to trauma and war, pandemic, new medical advances, and more. For us at the Katz Center, the series ties into the general theme that we're exploring across our programming this year of Jews and health, a capacious topic that encompasses research in a huge swath of Jewish cultural and historical experience, including bodies and embodiment, emotions and psychology, education, the theory of the medical arts, the social and institutional history of medicine and doctors, magical and mystical approaches to health, and much more. So this particular series focuses on activities and events taking place in Israel in response to the most current and pressing developments of our own day. And in that way, it serves as a complement to some of the more historically minded research that we share elsewhere, really hoping that this will help to promote a fruitful joining of past and present in the way that we think about Jewish medicine and experiences of health and healing. Professor Uzi Rebhun is the Shlomo Argov Chair in Israel Diaspora Relations and head of the Division of Jewish Demography, hi Uzi, and Statistics at the A. Harman Research Institute of Contemporary Jewry at the Hebrew University of Jerusalem. He's written extensively on international and internal migration, the Jewish family, group identity, Israel diaspora relations, and anti-Semitism, and has, for much of his career, focused on the demography and sociology of especially American Jews. You might be interested in reading his book, Jews and the American Religious Landscape, which takes a big picture view of the social, religious, and political patterns of American Jews in a comparative framework, so as against other religious groups. That came out from Columbia University Press in 2016. Or his important critical assessment of the demographic study of American Jews 50 years after the first National Jewish Population Survey, that was 1970. So that appeared in the American Jewish Yearbook in 2022. So ways to check out his work. He was also a fellow here at the Katz Center during our year on American Jewish history, which happened to coincide with the year of the COVID-19 pandemic. And now he's back for our year on health and Jewish medicine, working on a project dealing with the American Jewish response to COVID-19. So everything has sort of come into alignment. All of this positions him extremely well to present to us his general demographic and sociological findings about the Israeli response to the pandemic. So without taking any more time, I'll hand things over to you. Now, Uzi, welcome.
Thank you, Dr. Albert, for your kind introduction. I'm grateful to the Katz Center for Advanced Judaic Studies, the Weitzman Museum, and the Koret Center for Jewish Civilization for the opportunity to share with you some of my insights into the COVID-19 pandemic in Israel. And my point of departure, in line with the World Health Organization, is that this deadly virus was a pandemic, namely that it quickly spread over many continents and areas. And this enabled, I would say, even require that we assess the way that Israel coped with the pandemic in a comparative context to other modern Western societies. And I hope that through our discussion on COVID, we will also shed some light on wider aspects of healthcare in Israel. And my presentation has three parts. The first part portrays a few social and economic structural characteristics of Israel, which helped it struggle with the corona, and yet others that harmed or weakened the health of the population. In the second part, I will present a few major health outcomes of the corona. I'll focus on the peak years of the pandemic, namely from 2020 through 2022. And I'll especially examine the extent of morbidity, rates of mortality, and the effect that the corona had on the life expectancy of the inhabitants. And in the third part, I looked at a specific sector within the Israeli society, namely the Ultra-Orthodox, also called Haredim, which often adopted unique behaviors that not necessarily followed the command, take careful heed to yourselves. ונשמרתם מאוד לנפשותיכם. And Israel encountered the corona with a few advantages. Israel has a young age structure. In the early 2020, only 12% of the population were age 65 and above. This is the blue line at the bottom of the illustration. And this is one of the lowest rates among OECD countries, and it is especially salient in comparison to West European countries, marked in green, Oceania in purple, and the United States in red. And given the nature of the coronavirus, of respiratory infection, and therefore especially dangerous to elderly people, at least a priori, Israel works at a lower risk for developing widespread mortality. Israelis also enjoy an easy and convenient access to healthcare services. Unlike the United States, for example, Israel exercises a national health insurance, and this guarantee that every citizen can receive medical treatments of any type, no matter whether in times of emergency or not. And here I would perhaps also add that the standard of healthcare services in Israel is high, and Israel is ranked 10th among OECD countries according to an index which is composed of 5 different health variables. And as we can see in the graph that now is on the screen, Israel, which once again, the blue line, is ranked higher than countries such as the United States in red, New Zealand in purple, or the UK in green, just to mention a few. Further, the geopolitical status of Israel and its geographic location make it very difficult, perhaps even impossible, to cross the international borders of the country and to enter the country illegally. Moreover, Israel has only one entry gateway, namely the Ben Gurion International Airport, and therefore Israel was able to efficiently prevent, I would say even hermetically close, entry and exit of people at times of lockdowns. And when movement between countries was eventually allowed, Israel managed to tightly control and verify that the passengers meet both the local and the international criteria, such as pre-travel negative test, quarantine of confirmed cases who returned from abroad, and later the requirement that passengers are vaccinated. Israel is also involved in an ongoing military conflict, and therefore it is always in an immediate readiness for war. And this prepared the country to quickly mobilize its resources to non-security needs, such as the corona pandemic. And the transition from routine to emergency in Israel was smoother than in many other Western countries, and especially in the first months following the outbreak of the pandemic during the first lockdown, under a lot of uncertainty and lack of information. This preparedness helped Israel to encourage the citizens to comply with social distancing directives. It helped to distribute food, to track and document infected people, and more generally to apply different protective measures. And according to a study that was conducted by the Deep Knowledge Group in the spring of 2020, and that weighted a few dozens of indicators that fall under the rubrics of quanti-efficiency, government efficiency of risk management, monitoring and detection, healthcare readiness, regional resiliency, and emergency preparedness, Israel, at least at that time, was ranked the safest country in the world. Another important character of the Israeli society in the context of COVID is the high level of solidarity, the smallness of the country, past experiences in emergency situations shared by the entire population, the belonging of the overwhelming majority of the people to one given religious group, and the cultural codes of openness and mutual responsibility all contributed to the strong engagement of the civil society in encountering the pandemic. And various different indices, such as that on the screen, of social support in times of trouble, suggest that Israel is ranked approximately 10th among OECD countries, and in any case, above the average, above the yellow line. There are, however, a few factors in which Israel was at a disadvantage for managing the corona. The first is that indeed, as we have seen, Israel has a good healthcare system, but in this overall index, there are a few specific components in which Israel didn't do very well, and they were significant at the time of the corona. Low level of physicians per 1,000 population on the eve of the pandemic, as compared to 3.2 to 3.5 among OECD countries, and low number of hospital beds of 2.2 per 1,000 population, as compared to 3.6 beds on average among OECD countries, namely high occupancy rate of hospital beds at any given moment. And the meaning of this is that the duration of hospitalization is short, of 5 days, as compared to 6.5 days in other OECD countries. And therefore, patients are discharged quickly, sometimes before satisfactory recovery. So the hospital system in Israel is routinely overloaded. It is almost always at the upper end of the number of patients that it can absorb. And at time of unexpected crisis, like the corona pandemic, it didn't have any safety margin for a large number of new patients. Still, during the first weeks of the pandemic, the Ministry of Health provided a special budget for 500 new positions of physicians and added 3,200 beds, which were placed in parking lots, in protected spaces, and in areas that are not used normally to hospitalize people. And taking together the addition of physicians and beds, this somewhat narrowed the gap between Israel and other OECD countries. Another challenge that probably harmed somewhat the achievements of Israel at the time of the corona was the behavior of the ultra-Orthodox, or at least of some of the ultra-Orthodox of the Haredim, which comprised some 14% of the population. And different evidences that we have, some are direct, others are indirect, point to a large extent of disobedience to directives of self-protection against the virus among this sector. And in the tension between health considerations and the significance of praying in public, namely in a minyan, of studying together and celebrating in large gatherings the Shabbat, the holidays, the rite of passage events, the Haredim often preferred to continue their normal lives with only slight adjustments, but which were not enough and caused many of them to get the virus and to high rates of death. And against this structural backdrop, we can now direct our attention to the second part of the health outcomes of the corona. And in order to assess this, I chose a few objective, what I believe are straightforward incidences. And the first is the number of people who were infected with the virus. And here Israel, in blue, didn't do very well as compared to other OECD countries. For each 1 million inhabitants, slightly more than 500,000 got the virus, or to put it more simply, slightly more than half of the population. And this places Israel in the top 10 countries of contagion, which in this case attests to rather bad achievement. Still, in this part of the graph, there are other very advanced countries such as Austria or France or Denmark, all are in green. At the same time, Israel did relatively poor in comparison to the United States in red or to Canada in yellow. And I'd like to offer a few explanations, some speculations or informed guesses why Israel had high rates of people that contracted the disease. So the first is that Israelis are not always disciplined. So they do not rigorously obey to directives. Another explanation is the high rate of ultra-Orthodox in the population, among whom many continued to attend large gatherings. And here I'd also like to indicate that before the vaccine was available, many ultra-Orthodox rabbis and ultra-Orthodox leaders spoke in favor of herd immunity, namely white contagion, which will then remove different prohibitions that conflicted with their fervently religious lifestyle. And another explanation is that the Israeli authorities used different agencies in order to locate and document infected people, including the General Security Service, the Shabak, Health Insurance Fund, the Kupat Cholim, but perhaps most significant, Israel had a very efficient infrastructure that provided people access to official PCR tests, to institutional antigen tests, and home antigen tests that were controlled remotely. And therefore, it is possible that in many countries, not all the people that contracted the virus also took a test or were positively tested, but this was not reported to the local health authorities, and therefore they were not documented. And by contrast, Israel had a very strong and high correlation between the actual and the reported number of people who were infected. So the number of confirmed cases was high. However, the case fatality rate, the death rate among the confirmed cases in Israel was relatively low, about 2,500 deaths per 1 million infected people. This is the blue line at the bottom of the graph. This is one of the lowest in OECD countries. And for the sake of comparison, in Sweden, the yellow line, the rate was 9,600 per million infected. And in the United States, the red line as high as 11,000 per million. And these low levels or low rates of mortality from COVID in Israel are explained by the fact that many of those who got the virus were young, by the high quality of the healthcare services in Israel, despite some shortage in medical doctors and hospital beds, efficient tracking and monitoring of infected people, and also due to relatively good initial health condition of the population before the pandemic. And in the context of our discussion, I would especially like to emphasize this last point. Israelis, on average, are healthier than Americans and Europeans, especially in background disease such as cancer or health diseases or chronic lung disorder that are known to enhance the risk of dying among those that contract the coronavirus. And indeed, the COVID pandemic almost didn't have an effect on the life expectancy of the Israelis. A major health index of life expectancy that attests to the number of years that people are expected to live declined very modestly during the peak years of the pandemic. And not only that, Israel recovered and returned to pre-COVID life expectancy very quickly. Unlike the United States, for example, on the right-hand side of the slide, whose curve declined very steeply, and by the end of 2022 was still quite far away from where it used to be. I also would like to add that both among Israelis and Americans, the effect of the corona on the life expectancy was significant, especially among men and much less among women. And this should be attached, among other things, to a stronger awareness of women to the significance and to the importance of health, less opportunities or need to come in contact with people outside of home, and also better initial health condition, which is associated with less smoking and less consumption of alcohol. And this brings me to the third part, to a detailed look into an interesting group that challenged somewhat the healthcare system in Israel, namely the Ultra-Orthodox community. In this community, perhaps more accurately, those communities have their own social structure, their own complicated relations with the state, and values and beliefs that often conflicted with official directives and recommendations. And this generated a lot of anger among the general Israeli population, and several observations along different points of time, but mainly over the first 2 years of the pandemic, speak for themselves. The vaccination rate among the Haredim was 59% as compared to 89% among non-Haredi Jews. the rate of infection among the Haredim was 2.5 times higher than among non-Haredi communities. And the rate of Haredim age 65 and above that died from the corona was 3 times higher than among their counterparts, namely people of the same age group among the general Jewish population. And more generally, the ultra-Orthodox as compared to non-ultra-Orthodox tended less to wear a mask, were less likely to keep social distance, and they were less vaccinated, and therefore they had higher mortality rates. And this lack or only partial cooperation of the Haredim in the efforts to combat the corona mainly reflects the utmost importance that they attach to a full religious activity of praying 3 times a day in a minyan, in public, of studying together, having Shabbat and holiday meals together, and to distinguish, to lehavdil, participating in funerals, which are often very crowded. It also has to do with low trust in state authorities. Haredim also have limited access to the general media, but one also has to acknowledge that the police sometimes failed to enforce the law on this sector. And also many Haredim live in dense neighborhoods and dense apartments, which made it difficult for them to maintain physical distance. And finally, on average, Haredi women give birth to 7 or even 8 children, which means that between the ages of 18 and 40, they almost continuously are either planning to get pregnant or are pregnant or they breastfeed. And many of them, perhaps rightfully, hesitated to take the vaccine on which there wasn't enough information, not a lot of experience, and therefore suspicion whether introducing a new serum to the body would not harm their fertility or the health of their little babies. And by contrast, secular women in Israel have on average only 2 children, and often those women give birth within a short interval of only several years. So in sum, Israel, I think, did quite well in managing the pandemic, in ensuring low levels of mortality. And while there are, of course, things that can and should be improved, I think that the data that I presented are quite reassuring, especially as scientists and other experts expect more environmental and health catastrophes in the years to come. Thank you for your attention.
Thank you so much, Uzi. I'll just encourage anyone with questions to post them in the Q&A. And in the meantime, I think I'll start with one question, beginning with the final section of your presentation here about Haredi behavior and outcomes. And I wonder if you would be able to say a few words about how Israeli Haredi reactions compared to American Haredi reactions, if you have enough data or any kind of general observations about that. Or were they basically the same, or were they affected by the different contexts in fundamental ways?
I think that generally speaking, at least from the information and the data that we have, they approach and treated the pandemic quite similarly. And one thing that we found in both countries, in both communities, is that the Haredim didn't have anything special against the vaccine. although the weight of people, of the Haredim that got and took the vaccine was lower, but it's not because they reject altogether taking a vaccine, but rather they had some worried about the side effects of the vaccine. They weren't sure whether they have enough information about how the vaccine works. They thought that the vaccine was developed too rapidly. And also many of them already got the pandemic, already got the virus. So they had the PCR tested that they don't need to take a vaccine. So I think that this image that the Haredi altogether are against vaccination, I think in both countries are not supported by the data. Nevertheless, I think also in both countries, Haredi tended less to wear a mask, tended more to gather and to pray together. But I don't see any specific differences between the two communities.
Thank you. And then as a follow-up, that's comparative between America and Israel. Can we think comparatively across time about the Haredi response or outcome? So a question's been asked, was there any change, or are you able to identify demographically any change in the Haredi response to, say, other public health issues, or how the government deals with the Haredi community in Israel as a result of what happened or after the most intense COVID-19 era?
I think that eventually over time, both Haredi in Israel and the United States complied more and more with the directives and with the instructions. They understood and were aware that not complying caused a very large number of deaths. And I showed, I think, that the rate was 3 times higher among the Haredi than among the non-Haredi. I think that eventually here again, I have data both from Israel and from the United States, but especially from the United States. As time elapses, the rate of vaccination among Haredi and the non-Haredi eventually, not perhaps close, but pretty much converge to one another. So it took some time. They didn't want people from outside them, from their own community, to enforce them to do something. They were waiting for the rabbis to decide. The rabbis are those that decide for them, not the prime minister or the chief of staff or no one else. But eventually, I think over time, they realized that both face mask and vaccination have advantages, and the number increased over time, although I have to say that it didn't converge totally with the dose of the non-Haredi. I mean, the adaptation of protective measures among Haredim were always lower than among the non-Haredim, but the gaps did narrow over time.
Thank you. There's another question that's been submitted about the politicization of COVID policy. So in the US, as you know, there was highly politicized what kind of restrictions there would be, and even attitudes towards how much of a threat it was. Aside from the Haredi reaction, the question here is, was there also political division, right versus left, that was commonplace among Israelis?
I don't think so. The government that was in power in Israel during the pandemic was a very right-wing government, and they were part of the political coalition, and they supported the government, they supported the prime minister. So I don't think that there was any disagreement or any politicization of the issue of the pandemic in Israel. By the way, unlike in the United States, where we see that the number one factor that determine whether people comply with the directives and put or cover their face with a mask or take a vaccine was whether they are Democrats or liberals. I mean, this is true not only for Jews, but more generally to the American population. This is the most strongest predictor of whether people will comply with the work recommendations. And of course, those that supported Trump, they had the list or the lower number and weights of complying with the directives. I think that in Israel, it didn't have much to do with politics. Again, the government was a government of the right wing, a coalition of the Likud and the Ultra-Orthodox parties. So I don't think that there wasn't much influence of politics on the way that the ultra-Orthodox accepted or rejected different kind of directives.
It is a different alignment because here the ultra-Orthodox tended to then align with the political right in the US, right? Okay, I want to ask a question that might be...
I think it's because Trump was against the vaccine and against the face masks. In Israel, the prime minister didn't express any rejection of those protective measures.
Right.
So those are different situations.
Yeah, extremely different. The next question that I want to ask is possibly a kind of a meta question. It's about how you do the demography, how you do the statistical analysis, how you reach conclusions about this data. So, for example, you showed us that Israel had a much higher reported rate of infection and a much lower reported mortality rate. And you offered a few different possible explanations for that difference relative to, for example, the US or other countries, including real differences of outcome and also including differences of reporting structure, right? So I wonder, could you say a few words about how, as a sociologist, as a demographer, how you approach such a complex set of questions through the lens of these numbers that can only tell you so much?
Yes, so I'm a demographer now for almost 40 years, and over time I gained some experience and conducted quite a lot of studies. And I use different sources. Some are primary sources, some are secondary sources. In this specific study, I have the advantage of working on data in Israel, which have a very good and advanced data infrastructure that I was able to gain both from the Central Bureau of Statistics and from the Health Ministry and from different research institutes such the Koret Center, which did a lot of research on health in Israel and more specifically on the pandemic, on the COVID pandemic in Israel. So as you have seen also, each of the slides, those were not data that I myself utilized, but rather I retrieved from other resources. I gave them a credit. So, and of course, for the sake of comparison, I had to look in more international websites, such as that of the World Health Organization or the CDC here in the United States. I have to say that there are a lot of data, a lot of information that was gathered both officially and by private institutes and by scientists, by university scholars. There's an endless list of sources. The problem is not, at least in this case, was not so much where to find and how much to find, but the abundance of the data. I had to think how to put them together in a coherent format so I can present it to an audience within over 20 or 30 minutes. The things would be very clear and straightforward. So again, at least in this case of the pandemic, those of you that do wish to do research and use quantitative material, I think they are available. They are on different public domains. From time to time, I have to take the data and to translate it from translate the data from one type of format to another, from absolute numbers to weights or to something else or to percentages. Not very sophisticated for a demographer, for a statistician. But I have to say that I was very, my first time that I encountered this topic, following your invitation to give a talk. I very much enjoyed working with the data, and certainly encourage other people to do the same.
And as I understand, that's quite a different situation for you than the data you have available to look at specifically American Jews in terms of COVID-19. Do you want to say something about that?
Yeah, this is a totally different landscape, because in Israel, there's no separation between church and state. So all the data, the very rich data that we have, distinguish between people according to their religious belonging. So I can distinguish between the Jews and between non-Jews, and among the Jews, according to specific denominations of Ultra-Orthodox and Orthodox or seculars. Here in the United States, none of the official, of the governmental sources enable me to distinguish or to retrieve only data on Jews. So I have to look for data that were collected by private institutions or by private organizations. And here I mainly use data such as that of the Pew Research Center, which is a private think tank, but that collect on a regular basis data on different topics, not necessarily only on health, but also on politics and on race and on immigration and on identity, but also over the course of the pandemic of the last several years. It collected data on different complementary aspects of the corona, like masking and vaccination and illness, and also how the corona affected the religious identification of people. And they have a very large sample of people, and among them also a few hundreds of the respondents are Jews. So this is a robust number of cases that I can really utilize the data and get appropriate or sufficient results, robust results. Not only that, but I can compare then Jews with other religious groups. And in fact, this is what I'm doing while I'm staying here at the Katz Center. I'm comparing the Jews and other major religious denominations in the United States in the way that they encountered the corona pandemic.
Thank you. There's a couple of more questions that I want to try to get to here. So one, I don't know if you'll be able to drill down with this much specificity, but there's a question specifically about rates of obesity and how they contribute to health outcomes. The question specifically is whether the fact that the fact of compulsory military service or possibly other kinds of structural factors in Israel might contribute to a fitter, less obese population, which could have contributed to the better health outcomes. Can you speak to that, or does your data not?
Yeah, my data don't include any information on this, but for what I know, and I hope that I know correctly, obedience have a negative effect for those people who are contracted with the virus. And again, I think it takes me to one of the slides that I showed that the health condition of the Israelis as compared to people here in this country was much better. I think it is also true for obedience. Again, I don't have the data, but my very general impression is that the rate of obedience in Israel is much lower than here in the States. But I don't have much information or any information beyond this.
But it certainly correlates with what you've presented, yeah. So there's another question from a fellow about since you said that one of the factors that led to lower death rates among women is that they show a greater awareness of the importance of health. This questioner is asking if that's also true with respect to care. So some studies have shown that informal, mostly female healthcare constituted a huge part of the healthcare that was provided during COVID-19, in Spain in particular, providing up to 80%. And if you can say anything about perhaps the non-hospital or invisible home-based, more informal forms of healthcare that could be often provided by women, does that care structure exist in Israel, and did that play a factor?
Well, I'm suspect that I don't have any data or any information. Again, it's more kind of informed guesses or my own impression that there are more women in Israel that are involved in the healthcare services and healthcare system in Israel than men. I think this is quite obvious, and this is quite clear. And again, I cannot cite any numbers. But here, perhaps I'll also tackle this question from another dimension, because in another study that I conducted here in the United States, not necessarily related to Jews, we did see that women were more inclined shortly after the outbreak of the pandemic to leave their place of residence and to go back and spend and be together with their parents and family and to take care of them. So women, one of the reasons might be that they were less tied to their place work as compared to men. But I think it also attests to the more awareness and still the role of women of taking care of elderly people, of their elderly parents, of other family members, certainly at times of a health crisis. So I think that if we take a different observation, not necessarily directly related to your question, but overall, they converge into one quite strong conclusion that women have both better awareness of the importance and the significance of health, but they're also active in taking care of people in need, whether those are their family members or just part of involvement in the community, or perhaps even the work they are involved in, their professional work.
And in the start of your presentation, you pointed to one of the structural factors that promoted a positive outcome in Israel being a general societal embrace of mutual support and openness to taking care of each other, right? So it would be interesting to know how much of that activity was being carried out by women in Israel.
By women, again, I have no information, but generally speaking, and we see it also after October the 7th, the recruitment of people and the efforts of people to help others and to help families and people that were evacuated either from the north or from the south, and families whose children or spouses served in the army or were injured or killed. So the support on the part of the Israelis, both men and women, and not necessarily only women, is extraordinary. I don't think there's any other example in any other country in the world. So there is a very strong cohesive, despite the many political disagreements among Israelis, but nevertheless, at time of crisis, an emergency, we all get together and help each other and just come to Israel, walk in the streets every day, every place, every kibbutz, the demonstrations, in favor or against the government, but I think that Israelis are very linked. And there's a lot of mutual responsibility and mutual support among the population in times of emergency. COVID was one of them. Unfortunately, we're now facing another very different, but still an emergency situation.
Well, that's a very apt note to end this first program on as a part of our ongoing series on trauma and healing in Israel today. And I'll just note that our next program does deal with the aftermath of October 7th and the processing of trauma and people who are stepping in to help others handle that reaction psychologically. So that that is a talk by Karen Friedman-Peleg, and that's taking place 2 weeks from today. So I want to thank you so much, Uzi Rebhun, for sharing this data and this analysis with us so clearly and so carefully, and entertaining our speculative questions, as I know demographers love to do. And I want to thank everybody for being with us, and I look forward to seeing you all, or at least your names, all here again 2 weeks from now. Happy New Year, all.